this week on the BackTable podcast.
Regarding the issue of ergonomics, it's really the study of how the worker interacts with the environment. And one of the crucial things is to try and adapt the environment to the worker instead of forcing the worker to adapt to the environment. Essentially, there's been more funding for firefighters and, policemen and, other fields as opposed to the impact of ergonomics on surgeons. And I would love to see more funding mechanisms to further our understanding of work-related musculoskeletal disorders as well as interventions.
Hello, everyone, and welcome to the BackTable OBGYN podcast, your source for all things obstetrics and gynecology. You can find all previous episodes of our podcast on Spotify, Apple Podcasts, and on BackTable.com. This is a very special episode. We have a guest who is a friend and also a co-host for BackTable OBGYN. Happy to welcome Dr. Amy Park, Section Head of Female Pelvic Medicine and Reconstructive Surgery at the Cleveland Clinic. Welcome to the show.
Thanks, Mark. Thanks for having me.
No, we're excited. We're excited to have you to talk about ergonomics in surgery and gynecologic surgery specifically. But we also want to use this opportunity to introduce you to our soon-to-exist BackTable audience so they can know who you are and how you got to be where you are in your professional career, and also how you got to BackTable. So I would love to hear how you got to be where you are right now.
Well, just a little bit about myself. I grew up in California, and then I came to the East Coast and went to school in the Northeast. I went to Brown for college, and then I've sort of been in the East Coast and Midwest ever since. I attended University of Rochester for medical school. Then I went to McGee Women's Hospital to complete my OBGYN residency, and then I trained at the clinic for urogynecology fellowship. I was then in practice for 11 years at Washington Hospital Center, had a really great group there, and then was recruited back to the clinic to become the section head. And surgical ergonomics has been a big interest of mine. When I first started practicing, I was 35 years old when I came out of fellowship, and I was doing a lot of surgery, and I developed a shoulder problem where I couldn't raise my right arm past the horizontal plane.
Oh my goodness.
So I couldn't put a purse over my arm or my shoulder. And I remember thinking, I'm at the beginning of my career.
It's terrifying.
It's terrifying. As the primary breadwinner I still am the primary breadwinner for my family. And I was like, I cannot afford to have this problem. Fortunately, it didn't preclude me from operating, and I did not have to go seek medical attention or modify my practice, but it was definitely a wake-up call. And once you talk to more surgeons, almost everyone has had a brush with some sort of issue that has given them a scare or, required PT or surgery. And now that I'm pushing 50, it's just epidemic. And it's quite an interesting proposition because, in terms of surgical culture, I think traditionally we're trained not to talk about it. But once you talk to more and more surgeons, almost everyone has had a brush with this.
No, I definitely have had those days at the end of the day, especially maybe the next morning, where you're just like, did I just get hit by a truck or something yesterday? I don't feel right. I don't know if you played sports or anything else, or any other, like I played drums for 30 years. And so like my right shoulder is not a normal right shoulder. And as a laparoscopic surgeon, there's definitely days where you feel it and makes you think about it. I've been lucky so far, but it is a scary thing. And I know doctors who've had to go to PT. I know doctors who've had to have surgery. I know that this is something that actually just got an email this morning from a colleague outside of my department who is emailing a bunch of us who operate and saying, hey, one of our residents wants to do a study on surgeon ergonomics. And I'm like, oh, I can't wait to tell her about the show. Like I got the email this morning because I think it's something that is so critical to allowing us to do this job. So I was really excited to have you on the show in general, but specifically to talk about this job. Before we jump too much into the meat of the show, though, talk to me about like your practice now, what your job is like in Cleveland. What's your day to day? What's the bulk of your practice?
So I'm fortunate to be part of an institution and a group that really has been seminal in pushing forward in innovating in the field of urogynecology. So my practice and my day-to-day really encompasses like the traditional academic three-legged stool, like in terms of the clinical, including surgical aspects and research and education. We do have a fellowship, and then we have a tracking OBGYN program at the Cleveland Clinic. I'm usually in clinic.
And you mean for tracking, you mean surgical track versus obstetrics track? Or
Yes. So there's only 2, and now I think 3 OBGYN tracking programs in the country. We are the longest standing one. I think it's been 10 years since Dr. Jolosik, who's now at Duke, founded this program along with Dr. Falcone. And then I think Mayo Clinic just started a tracking type program. And then Swedish, actually one of my co-residents is the program director there in Seattle, just started a tracking program. But it's quite innovative in that the residents do have to do a certain number of rotations in order to complete ACGME requirements. But within that, there's some flexibility in terms of tracking rotations where they can choose to do more MFM or family planning or urogynecology or oncology or do an away rotation. We had one of our residents recently return after doing a breast fellowship, and she actually was able to do more breast cases than a lot of general surgery applicants just because of the flexibility within our program.
We should do a show on that. We should talk about
absolutely
the challenges in resident education and surgical and obstetric experience. Now that's fascinating.
It is.
It's awesome.
It's pretty interesting. I mean, it requires a lot of introspection and drive on the part of the trainees who choose to enter this program, because you have to write a justification for what your tracking block is going to be and your reasoning and what your goals are, etc. And it also on the part of the program and the institution requires that you do not rely on residents for service. So
wait a second, hold on. How are you supposed to run a residency without relying on them for service?
I mean, that's
a whole other novel.
Yeah, so it's I don't have resident coverage for all of my cases. Like there's definitely majors that go uncovered. And so
you have surgical assistants that you guys have.
We have
available
PAs,
for that,
our main hospitals, main campus, we have residents pretty much covering every case, but at the other hospitals, we'll often have a PA. So I'll have vag his that go uncovered.
We're just starting to do that now as our program's grown here too. I just hired a partner, and my urogynecology partner we just hired another urogynecologist as well. And we've, our residency program hasn't grown, so we're going to have a lot more volume without more coverage, and we're figuring that out too. But other ergonomic challenges in not having the assistance and the support maybe that you thought you had before. But I know you've done research. I know you've written on ergonomics and talk to us a little bit about work-related musculoskeletal disorders, like what we know about that, where that all started. Because I don't think I heard about that once in training. Speaking of residency, that's not anything anyone ever talked to me about. Like, oh, here's how to protect your back and shoulders. Like when you had this shoulder issue, like what were the next steps for you in that process of discovering what that all was about?
Well, I think you mentioned the crux of the problem, which is essentially a lack of awareness surrounding this issue. And I think one of the things that really has been a positive development in the last couple of years is the focus on wellness and the promotion of a culture where it's okay to pay attention to yourself and to prioritize work-life balance and, all of the things that go into that. And I think this definitely falls within promoting wellness, career longevity, and, preventing disability and career modification in the future. Regarding the issue of ergonomics, it's really the study of how the worker interacts with the environment. And one of the crucial things is to try and adapt the environment to the worker instead of forcing the worker to adapt to the environment. The whole thing with work-related musculoskeletal disorders is the problem of, in this case, surgeons trying to adapt to the environment in maladaptive ways. And there's a number of factors that contribute to that. Prolonged static positioning, vibrating tools, cold, and then just not having ergonomic positioning overall. And what I mean by ergonomic positioning is essentially we want to try as hard as possible to keep a neutral position. But I want to just circle back and just state this is an epidemic, and we have workforce issues that are affecting healthcare. We see it with the nursing shortages right now, and that's a crisis that essentially has been 20 years in the making. There aren't enough nursing positions or spots open in training because it's I just read this big article in the Clue and Plain Dealer about this, but essentially there's not enough spots in nursing school because it's the nursing teaching positions pay less than the clinical. So there just aren't enough teachers out there in nursing school. And then there's mass retirements happening and epidemic burnout. So it's a quite a number of factors contributing to that. In the medical field, we also have limited number of positions, as you know, in terms of medical school, residency spots.
Well, they've increased the number of med school spots dramatically without really adjusting the number of residency spots too, right? So you have this whole other epidemic of unmatched medical students. And every single year on Match Day, I tweet the same thing, which is medical schools need to own it. And if they have students that do everything they ask and don't match, they should get their money back. That to me should be part of it. There should be a guarantee. I think it's crazy to think that you could go all the way through med school, take all those loans, pay for everything, do everything you were told, pick a specialty that matches whatever your CV looks like, a reasonable suggestion. And if you don't match and do everything right, there should be some accountability on that side too. But
yes, it's huge problem. And now I think there's more acceptability to having DOs join residency programs. So it's another slot problem in terms of residency. But essentially, we have this workforce that is limited in terms of the number of training spots. And then we have a huge demographic bulge coming up with the baby boomers. I mean, I can tell you myself, my payer mix when I started practicing in 2009 was about 30% Medicare. Now it's about 39 to 40%. And you're seeing a huge bulge demographically in terms of aging population, no increase in the number of physicians, and particularly there's going to be a shortage of surgeons. So I see this as really an imperative, both on the individual level, but also a workforce issue level. And I know for us, we're definitely seeing it for the anesthesia side. We're, one of the hospitals that I work at, the anesthesia staff are retiring. Same kind of thing. They're, I think the average age is like 55 to 65 and they're burned out and they're like, sayonara, see you later, folks.
And all that puts more pressure on those of us who are operating, right? Your patient population is aging, right? So that's most of your patients are, going to be older than a surgeon like me who deals with endometriosis, more reproductive age things. Urogynecology patients are going to be older than our patients. So your volume's going to go up with the age of our patient of our population in this country as the boomer age grows. You need to operate more. There aren't more of you, right? So you have to somehow take care of this population that's growing. You've got to operate more and more demand on you physically to keep up with all this without the system support that you're describing. So we all see where it's going, or at least those of us who are paying attention see where it's going, but I don't know that any of us necessarily have the answers because I don't think it's a simple answer. It's a systems answer.
Yeah.
It's going to be...
It's a problem.
It's a 20-year answer, right? The nursing shortage, those things, it's a 20-year. It's okay, create more nursing educators so that you can create more nursing spots in schools. So in 10 years, we can have a few more nurses.
I mean, there was a big systematic review published in JAMA Surgery a couple years ago by Epstein et al. And essentially 12% of surgeons and proceduralists reported either career modification, disability, or premature retirement due to work-related musculoskeletal disorders.
12%?
Yes. So it's most likely an underreporting, because if you look at the individual aggregate studies, the numbers are way higher than that. They're like 40% of surgeons, 70% of surgeons. It just depends on where you're slicing it and who, how high the survey respondent rate was.
I mean, if I'm talking to my colleagues, it's 100%.
Right.
That have some, maybe they're not in PT, or maybe they're not requiring a medical intervention. But like, I've been lucky that I haven't had to go see anybody, or at least whether I'm supposed to, I haven't. Like, it affects everybody after a long day. There's no way to go and do what we do without having some physical impact. And I'm 10 years out from training. I hope to be doing this for quite a bit longer. And I have to think about the ways that I can do that safely, because I like what I do. People are counting on me doing what I do, and I don't want to have to miss time or stop doing what I do because of a physical disability or limitation, especially one that's potentially preventable.
Oh, absolutely. And I think, surgeon culture traditionally has been putting the patient in front of our own concerns.
In spite of the data that says put yourself in a position to better care for patients by taking better care of yourself, right? That's not the culture, the predominant culture, at least historically, that we were trained in, right? It was always, like you said, put the patient before everything else.
Yeah, and it's just like there's all this patient safety culture and the analogies with the aviation industry, and we should be putting the oxygen on ourselves first before we put it on our children.
Love that.
It's the same type of thing with these maneuvers that don't actually adversely impact the patient, but really can impact our career longevity. And, one of the things, there's many, many things that go along with surgical ergonomics, but I think the first step is awareness. The surgical culture of like pain is weakness leaving the body, put the patient first. We don't stop for breaks.
A lot of similarities to competitive sports, right? Where it's just like you have to power through things. And, I think even especially now in sports, most obviously, I think in things like football, where players are stepping away from the game. I mean, even in basketball, players are stepping away from the game earlier and earlier because they're playing more games at a younger age and their bodies are wearing down. One of the things that I think that I want to talk about in a few minutes, though, is just the different approaches and how we operate differently now than we did 10, 20, 30 years ago. But before we get there, when we talk about ergonomics, I want to think about, because I like how you put it, we're adapting the environment to the surgeon, not trying to adapt the surgeon to the environment. And I think, we think about something as simple as just like how you stand in the OR, what kind of shoes that you're wearing and those kinds of things. And so like when we talk about just simple individual ways to improve our ergonomics in the operating room, what types of things are you talking about? And thinking maybe just starting with like normal open surgery, what are things that you see? What are injuries that are associated with that versus other approaches?
So with particular to the open approach, if you're using loops or headlamps or the table height is inappropriate, you can get a lot of excessive neck flexion. And most of the studies show, about 60 to 70% of the time in the operating room with excessive neck flexion, excessive trunk deviation, as well as abducted arms. I know the listeners can't see it, but just recreating the scene at a OR table, if the table height is too high or too low, and having to put your arms and your shoulders outside of, really in a forward position,
out wide or
forward. I think not adjusting the monitors and the foot cords and the step stools in an appropriate manner I think the nothing we can do about stature. I mean, you're either born short or tall, but the extremes of height can be a problem. And
No, I trained with, I mean, I was one of the taller people on my program, and most of the people that trained me, if not all, but most were shorter than me, and adjusting, I would sit for deliveries because if I stood in training, not many people could help me.
Yeah.
And things like that. I think that as you're saying this, I'm having these flashbacks of being a medical student and, contorting your body in a certain way and holding a retractor. And as I've gotten more aware of surgical ergonomics and my own positioning, I've made it a priority not just to think about my own positioning and how I'm standing or how I'm sitting. But if our med student is like leaning somewhere, like, all right, hold on, let's stop where you are, go ahead and just like stand up straight. Like, or our residents, a lot of times the IV pull during a laparoscopic case is like way too far forward. And they're hunched or turning sideways, or their shoulders are way up and out, or you can tell they're not standing in a normal ergonomic position. And part of that is educating trainees, not just about how to move through the steps of a hysterectomy, but understanding how to stand during a laparoscopic hysterectomy. And I do a lot of that, less formally, but it's definitely something that it does impact not just how they're operating today, but knowing that this is good. If they learn to do it the wrong way, they're going to be hurting, and they're young, and they're all young and healthy and don't care about suffering now, right? In training, because they don't want to be a bother, right? And so it's the kind of thing they're never going to say anything unless we proactively say, "Hey, stop. Let's get a step stool for you or something," right? So I think being an active teacher in this is a huge part of it.
I totally agree. And setting up the field and adequate exposure is crucial to being a surgeon, but also paying attention to your team is a skill. And when you're trying to learn, it's really hard to pay attention to yourself and the way you contort your body. It's just not something that people are tuned to. So we as the teachers have to help the trainees and the learners be aware of what their positioning is, just like coaches do for the athletes. And I always say the surgeon should be considered a high performance athlete. We should be paying attention to our diet, to our sleep, to our exercise, to all of those things that contribute to our physical and mental performance. Lack of sleep never did anybody any good, okay? Michael Phelps is getting probably 8 hours of sleep a night, and he's getting massage, and he's getting PT, and he's getting rolled out, and he's doing all of these things.
Tom Brady and LeBron James care a lot more about their diet now than they did when they were 18, just getting started in this game, because they understand to keep doing what they're doing at that level. And I'm not trying to compare myself to those guys, but I do think that, doing a hard physical thing for decades, it's easy for little things to become big things over time.
Oh, absolutely.
And I think it's essential.
So, going back to what you're saying about what can we do to mitigate these problems, using anti-fatigue mats. Like I have one in front of where, when I wash my dishes, but using the appropriate footwear.
So just like a squishy mat.
Yeah, the squishy mat. They should not be called princess pads because there's nothing princessy about like protecting your health. Having the appropriate footwear.
What does appropriate footwear look like? I know all the anecdotal things about what people say works, but is there any data on like certain types of footwear actually can improve back pain? Do you know of anything like that? I don't know if I've seen that.
I haven't seen any studies on it, but you want to get some a rollicking discussion on social media, on Facebook or Reddit. People just ask about footwear, and people have their favorite footwear brand: Dansko, Calzuro, Hoka's,
cowboy boot crews as well. Yeah. People love their cowboy boots in the OR. Which
exactly. But
not for me.
But I think that other things that we can do that are pretty achievable is, in terms of table height, we should be able to set up the field, the IV pull, the way that our trainees are holding the retractors, self-retaining retractors, making sure that the monitor height is appropriate.
I just started doing that. I was preparing for this talk, is my monitor heights were way too high, and I think that was causing me to have some neck strain. If I'm the tallest guy in the room, everybody else is worse.
Yes,
everybody else is looking up higher than I am. So having that monitor low. So we talked about open surgery. Laparoscopic surgery is a whole other a whole other series of potential problems for pain. Monitor height for laparoscopic surgery is something I hadn't really considered.
Yeah, it's huge. Monitor height. And then, there's a lot of neck strain associated with all the modalities of surgery, open, laparoscopic, robotic, vaginal, which is very particular to OBGYN.
Well, now there's more there's more natural orifice surgery, right? So there may be more and more folks who are performing natural access or natural orifice surgery.
The V notes I think is hot. I think the use of Trendelenburg is underrated. I mean, I know you know because you're laparoscopic surgeon, so you use it all the time. But in vaginal surgery, I think that's key to getting access to an exposure for, and we should be using that all the time. And when you change the surgeon, you change the height, and you need to adjust appropriately. And I'm going to circle back to the neutral position because there's all sorts of things like not flexing the neck more than 25 degrees, but that's really hard. You don't know 25 degrees, but you kind of know what a neutral position is. So you want your neck not to be excessively flexed or extended, not having a lot of excessive trunk flexion or extension, not having the shoulders out abducted too much. You want to have your elbows at sort of a 90 to 120 degree angle, have the shoulders closer to the body, and sort of retract the shoulders a little bit so that you have a straight posture. And you want to make sure that your weight is sort of evenly distributed and not on one leg. The thing is about using the foot pedals, I know I use the stools when I'm doing laparoscopic sacrocolpopexies because of the table height issue, etc. But, keeping your one foot on the stool and then another foot cocked on the foot pedal is also sort of an unnatural position to keep for a long time.
So do you have the foot pedal on a separate step up, or do you have
I do.
that on the ground?
No, I have it on a separate step up, but still in terms of keeping your weight, if you're doing a lot of cautery, your foot is just kind of like, and you can imagine, I mean, having your foot like cocked like that for, and your tibia, in that position for a long time is not good for your body. And I know when I do a lot of laparoscopic surgery, it's so hard on all of the modality of surgery are just hard on your body. But particular to laparoscopic surgery is the ergonomics of the instrumentation and the handles.
So that was the two questions I had for you. So so let's talk about that, about the instrumentation, and then the other thing I want to talk to you about after that is the next evolution of laparoscopic surgery, which is the robot. And so because I think those are both things that I've paid a lot closer interest to. I did a ton of robotic surgery in fellowship, spent the last 7 years doing no robot cases because of the hospital I was at and because it wasn't part of my practice. But now that I've started thinking more about ergonomics, I've started reading more and more about robotic surgery and its impact. So let's hold off on robots for a second. I want to hear from you though how the instrumentation can impact the user, the surgeon in these long cases.
Well, first of all, the handles are too big for many surgeons who have smaller hands, and there's many studies showing that glove size of less than 6.5 and shorter stature, which kind of go together, obviously, it results in more strain in terms of hand, wrist, arm, shoulder pain. There's only one instrument, I think it's a harmonic, where actually Kelly Wright, who's a MIG surgeon, was a biomechanical engineer prior to her life as a surgeon. And actually they modeled the instrument on her hand. And so it's a smaller handle. And I see a lot of MIG surgeons actually using that when I watch the surgical videos. I'm the SGS program chair, so I've watched a lot of videos. And it seems like it's the bipolar instrument of choice for many, many, many MIG surgeons. And I think because the handle's easier, but it's also pretty good for the kind of energy is pretty good for endometriotic type dissections and etc. But regardless, the rest of them are very wide handles, and it's just hard. I mean, I use the ligature, and I tried using the I usually use the blunt tip, but I used the Maryland tip one time, and I really like the Maryland tip, the tip itself, but actually putting my finger on top, it's just too hard to try and stretch, and you get a lot of strain, for example, using that. But then switching over to the general surgery crowd, I follow a lot of the general surgeons on social media, and they talk about how they can't use a stapler with one hand, and they have to use a two-handed stapler approach. I mean, I think that's terrible. And then the issue with palming the instruments, I think is also very, very difficult. I think the table height issue, the instrumentation, and the design will require partnering with industry and a ground swelling on both on multiple levels. Obviously, industry, the surgeons, institutions. I saw a really great talk by Dr. Adrian Park, who has been in this niche for a long time, doing a lot of research. And he made the point that the operating room has not been redesigned for over a century. Like, it's essentially been the same for a long time. And we should be using the input of human factor research in order to design the OR of the future, because the future is now. And I definitely agree with that. I mean, I do think that obviously there's been a lot of progress in the technological innovation and the monitors and the mics and all of that other stuff. But I don't think that we have necessarily incorporated the ergonomic aspect.
It's almost an afterthought, though, or not almost. It's an afterthought. I mean, they design the hospital we're operating in now is 40, 50 years old. Didn't have laparoscopic surgery when any of these ORs were designed, let alone robotic surgery. I mean, trying to squeeze a couple of surgeon consoles and a robot into a room designed for something where you would have an open, open tray, and that's it in these rooms. And so just physically fitting the stuff into a room that they weren't designed for is how most of us are probably working right now. Because unless a hospital was designed last week, they're not up to date. And hospitals were designed 10 years before they're built, all those things. And so, trying, like you said, trying to make it fit, trying to work within what we have, I think it starts with individuals like us teaching ourselves how to operate more safely, ergonomically, and then teaching our residents and students to take it more seriously and to make sure that they're speaking up, because they're never going to say anything. They're never going to say they're uncomfortable.
I find myself doing that all the time. I mean, I basically am saying, let's adjust the table. You're flexing your neck too much.
I'm the same way.
Seems
I'm
like
you're not, you look like you're uncomfortable, like you're squinched up there. Like, just move that IV pole, because they don't want to bother the anesthesiologist, and God forbid they have to put down their Sudoku to fix the IV pole for a second. But I'm just kidding out, like our anesthesia colleagues. But no, I mean, and they're always happy to help. That they want the surgery to go smoothly. They want everything to go well, just as much as we do. But giving them the sort of coaching that, hey, you got to speak up and advocate for yourself. It's not a sign of weakness. If this is how you do surgery, and how you do it well is to put yourself in set yourself up for success, right? I tell that to my students, to my residents, to my kids, like set everything up. And I do that when I'm setting the table up. All your cords, there's no, snake's nest of cords. We make it look a certain way, so we're not distracted by those things. How you're standing is part of that table setup. And I think that's a good opportunity when you're preparing to operate, before you make any incisions, before you do anything. When you prep and drape, like, set yourself up for success. Stand or sit or however you're going to be operating. Set it up now instead of an hour in where you're like already tired and the case isn't going well and your things start popping up. And so teaching that at the beginning.
I agree with you 100%. I mean, we are so big on patient positioning and making sure that the hips are not overly flexed or extended, tucking the arms.
I tuck my arms by every single case. I'm like crazy about it.
Yes. And that it's padding so you don't get a perineal nerve injury. This is part of the whole deal is, setting up your field, setting up exposure. We should also be optimizing surgeon positioning. That should be part and parcel of all of this, because if we don't have enough if we don't have the right posture, we're not maximizing our potential.
And if our workforce is limited, we're talking about this, or, like you mentioned earlier, we got to make sure the workforce that we have here is going to be healthy enough to continue to do this hard job for the next 30 years, right? Those trainees and students we're teaching now, like they're going to be the ones that are the workforce after we're retired. And so we need them to be doing this a long time. We have to prepare them how to do this job a long time.
Well, just as, we are there to train the trainees and how to do surgery, we have to teach them how to be in tune with their bodies. I mean, that's why I like working out with a trainer, because, I'm doing my back squats and I'm leaning all the way to one side to avoid my left knee problem. You know what I'm saying? Like, we should be teaching them to have body awareness that this is an awkward position. And I see my trainees doing dissections in a non-ergonomic manner, and it's going to down the road lead to carpal tunnel or what have you. And this research has borne this out, that inexperience or younger age puts you at risk of developing work-related musculoskeletal disorders. So as we age, we gain that experience. But, I always say this, and I just said it to my kids the other day, like, judgment comes from experience and experience comes from making mistakes. So I don't want you to have these problems that I had. And I want to teach you how to get the appropriate exposure without having, incurring the damage, the complications, the mistakes that I made. So, because you can see the pitfalls once you've done them. And that's the whole, I think, rationale behind M&M is like, how can we learn from this and avoid this in the future, or make it better, or, know how to respond, or what have you. And that's the same with this ergonomic issue. I think,
and talking about it, I mean, like you said, it's not a sign of weakness. If I'm telling my residents, like, my back's killing me because I didn't do this right for the last 10 years, here's how you're going to do it so you don't have to deal with the stuff that I'm dealing with. Or I had a friend who hurt their hand operating a certain way and can't operate again, or, shoulder issues and those things. And making it a priority in the OR. And I do that a lot in my practice in general, is try to be open about my challenges that I've had along the way. And part of doing a show like this is so we can share these experiences, because I think a lot of us feel like we're the only ones that are dealing with this, or we're embarrassed to talk about it. But this is so important to allow us to do this job that everybody, I think if you ask them, if you just asked enough questions, they would say there's something that bothers them about doing this job after so many years. It's not hard to find anybody who's had these issues. What are ways going forward where technology can help us out, though? I mean, I just hopped back on the robot after a few years because I'd read a few things that there are potential opportunities for less ergonomic strain compared to traditional laparoscopy. That's not why I did it, but like having residents, and you need to get back on the console and training and those things. But there does seem to be some potential for improvement in, work-related musculoskeletal disorders with different technological advances, and the robot being one of those potential advancements.
Well, if you look at the data, it does suggest that the robot is associated with a little less strain and work-related musculoskeletal disorders, but it really depends on experience. If you have to look at this at the data with regards to certain subgroups.
How much of it, right, is just people not standing the right way, not setting themselves up correctly, as opposed to the instrument itself?
Well, the thing is, I mean, yes, it sounds more relaxing because you're sitting at a chair at the console. But if you don't adjust the console to the right height, if you don't have a chair with lumbar support, if you're sitting with your, more forward in the chair instead of having the entirety of your upper leg like on the chair, with lumbar back support, with the arm rests out to the sides, and having the wheels locked instead of, because you can easily push against the console with your forehead and just start moving back, and then you're going so forward that you can't, and that is something that
hospitals will spend $3 million on a robot and not spend $600 on a chair.
Yeah,
I mean, that's the truth. Like, oh, you just use this stool. It's like, but I'm rolling away from the robot in the middle of the case. I keep having to scooch up.
Yeah, you have to either lock the wheels, or you have to put a rolled up blanket behind it. You need to have the surgeon take 1 minute and adjust the height of the console because obviously people are different heights. I saw this great picture of a pregnant resident trying to be at the console, and her legs were like so squished in between the fetus and the console, and you have to make sure that your shoulders are retracted and you're always be clutching so that you're in the neutral position instead of going like this and shrugging your shoulders.
I feel like there needs to be a whole other like study on how pregnant physicians can improve their ergonomics. I mean, I'm blown away by my colleagues who've been working all the way up to term, moving beds and doing these really hard things that we're talking about. Oh, also being term pregnant, and it's just mind blowing to me as somebody who talk about instruments designed, OR designed. I'm a 6-foot male, right? So everything's just kind of built for me. That's kind of how things were designed. And it's basically everything that I'm talking about is worse for everybody else.
It is tough.
It seems awful.
It's well, that's funny that you say that because my the two stories when I was pregnant and I was operating until I can't remember 34 or 36 weeks, I was sharing this office at the clinic with 2 fellows who are from France, and they were like, "What are you doing here?" They basically, in Europe, it's particularly in France, like pregnant residents aren't operating past like, I don't know, 3rd trimester, like early 3rd trimester. And they were like, this place is barbaric.
Of all the specialties that should think about, if we're talking about putting women's health at the forefront of what we do every day, most of us who do this job are capable of getting pregnant, right? Like the vast majority of our trainees, right? And yet we do very little, I think, across the board to think about the ways their training is different than mine and things that we can do. I mean, it is something I've been talking about for many, many years about like.
I don't know what the right answer is because, I as looking back on my pregnancy, it's not like I would want to miss out on cases just because I'm pregnant because there's not really a mechanism for flexibility in the current situation. But our residencies and fellowships do span our prime years of fertility. So I don't know what the right answer is for that. But the other story I have is I was talking to human factors PhD, and she's basically dedicated her whole career to, surgeon ergonomics. And she was telling me that when she first started her career, she got her PhD and she went to a meatpacking company. And this factory was basically designed for German settlers in the Midwest. And the whole factory line was designed for, 6-foot tall guys, like, or whatever. And then the workforce changed and it was a lot of immigrants who were just a different stature and they were getting swept away on the factory lines, like literally. I mean, I'm laughing, but it's terrible. And she came and she watched them doing their meatpacking thing. And she was like, you do not need a PhD. Like, you just need a set of eyeballs to see what is going on here in terms of like the design of this place is not for this current workforce, and what you describe is totally correct. I think that the nice thing is now we have a pretty good momentum in terms of raising awareness. And, I'm a co-founder of this Society of Surgical Ergonomics, and it's a multidisciplinary group with
talk about that a little bit.
Yeah. So there's like, we came together on Twitter because we were all very interested in it, mostly motivated by our own health scares and personal experiences. And, it's general surgeons, urologists, me, neurosurgeon, and just, I think there's definitely been some early wins. Like we just had our first symposium and the American Journal of Surgery is supposed to be our journal for the papers from that meeting. I think that another early win was there's a SCORE curriculum, which is analogous to our CREOG curriculum, and they have a surgical ergonomics component in that.
Is there anything about ergonomics in our resident training curriculums? And is that?
No, currently not. And I have lobbied my APCO CREOG contacts, but APCO is more focused on undergraduate medical education. So the medical students transitioning into residency. So we don't currently have that. And then the third thing that was an early win, because this society has only been in existence for about a year, maybe a little over a year, is there was a trial called the FIRST trial, and it was a multi-center trial. And it was basically, we had a similar kind of survey that was administered prior to our CREOGs, but they administered it to the general surgery residents before their shelf exams. And it basically showed widespread burnout, depression. It was dark. Just like our CREOG type surveys were illuminating in terms of the insights. So the next step of that first trial, it's called the second trial, is the intervention component of that, addressing wellness in burnout in general surgery residency programs. So programs are essentially randomized to controls, which is just as is, versus intervention programs or curricula. And surgical ergonomics is one of the modules within the second trial. So, if you go to the second trial website, they discuss some of the parameters, what they are using in order to address wellness and mental health and burnout in these programs. And so I think there's been a lot of movement in the last year to try and address this because everyone acknowledges that this is a problem. And, circling back to your question about the robot, I would say robotic, maybe better asterisk if you have the appropriate posture and techniques to avoid injury.
Or just an opportunity for a new kind of injury.
Right. I mean, I think I've seen my colleague who I just wrote another ergonomics paper with, she sent me some pictures of people on the console, and you could tell the height is not correct. They're really pushing their foreheads into the console. Their bottoms are really far back, with the chair. They're too flexed or too extended in terms of their hips and their knees at the console. And their elbows are like off.
And you'll see people kind of chasing their pathology instead of moving the camera and like centering themselves a lot too. And if you're not used to doing it a lot, you can see people really reaching or like being squished up, instead of centering their hands in a more neutral position.
Yeah, and their shoulders are like this.
Right.
Because they're not clutching and they're not recentering. So I think if you have awareness and you can position yourself and just readjust yourself constantly, but I think you can incur the same damage on the robot. And actually, I do know somebody who essentially snapped his wrist tendon on the robot. So unfortunately, nothing is safe. All we can do is mitigating measures.
So it sounds to me like, yes, there are technologies that have potential for reducing certain kinds of surgical injuries, but there may be new injuries associated with it. And ultimately, it comes down to education. So educating the educators first. You and I have to, learn what good ergonomics looks like. We have to then educate our trainees. We have to, not just by example, but make sure they understand what the right way to do things looks like, where to stand, how to stand, where to put your instrumentation table, monitor, patient, all those things, making sure they understand it's a priority. And that's where CREOG and those educational institutions come into play, where we actually need to think about creating systems that educate our trainees and to create better habits. Because if we teach them wrong, they're going to do it that way forever. And so if we're going to protect our workforce, if we're going to make sure that our patients get the best care, I mean, if I'm in pain, I'm not operating as well, right? That's ultimately, it's about patient care. But then lastly, what you do and what we're grateful that you do is, in addition to all the hats you wear, but is studying this stuff and being a voice and, creating this ergonomic society and doing the research to understand where the problems are. And so we can create better interventions. Certainly innovation is an opportunity to, technological innovation specifically is an opportunity to improve those, but that's going to take a long time. And there's a lot of people right now who need to better understand how to take care of themselves today so they can do this job for a long time.
I agree with you. I think some of the things that are really exciting to me right now is, number one, I love the fact that you told me your resident wants to do a project on this. This is not going to be a problem that we can solve with onesie, twosie, like one-off type of research. Like, this is going to take a movement and many, many different actors to make this, to give us insights on what the best path forward is. And it's going to take everybody coming together to research and raise awareness and educate and figure out solutions. Second of all, when I watched this symposium, it was now like probably 2 or 3 weeks ago, there was just so much exciting stuff in terms of potential solutions. And when you asked me about innovations or technological solutions for these issues, some of the things that were super exciting were just looking at how people are using, in terms of defining the scope of the problem, these inertial measurement units. I mean, they're very expensive right now. Hopefully the technology will go down in price. I mean, somebody else just approached me about doing something along those lines in terms of objective measurements. But like, in order to get these units, they're like $18,000. So she has to get grant funding just to get these units. But in terms of interventions, the use of these exoskeletons that have like active and passive support. Somebody else told me that he had been working on an Xbox related solution where, it would give you a little buzz if you weren't in an ergonomic position.
I think that I feel like I've seen those like for posture, right? Like if you're slouching,
Yes.
you put these things on your back and it'll give you a little physical reminder that you're not sitting the right way. So yeah, that's exciting. And this is the Society for Surgical Ergonomics. Is that the name?
Yeah. And then the other one that I saw that was super cool was like an artificial intelligence powered real-time ergonomic assessment. So it had somebody like it was actually like in the sim lab, but it was someone who they had the little, drawing on the person and on the video, and they were assessing, the ergonomics. And that'd be cool if you had somebody, every other person can go to the running store and they can analyze your stride and your golf swing. And we don't have that for surgeons and ergonomic assessments. You can have someone in your institution come and analyze your desk setup.
Yep, we have that. The ergonomics experts and see where my chair height and desk height is. But yeah, do we have that for surgery? And I don't think we do.
We don't. I mean, certain institutions do. Like I've seen someone posted on Twitter about you can have somebody come to your OR to analyze, and then somebody else.
I bet it's not free. And I think that's where we have to, like the last thing I'll say here, I know we probably got to wrap up for you. I know you're busy, but the work you're doing is so important, not just in the research and in the ideas and the innovation, but is bringing awareness to the value of surgeon ergonomic improvements, because there's going to be a cost to surgeons not being able to operate. There's going to be a cost to early retirements. There's going to be a cost to all these things. And if ultimately the goal is for all of us to be able to stay in the hospital and operate and keep this machine going, hospitals need to understand the value. The industry needs to understand this is important, and they need to show that importance by funding the research, by funding the tools required to not only study but also improve ergonomics for those of us who do this job. And so I'm incredibly grateful that not only are you one of our co-hosts here for BackTable OBGYN, I'm also incredibly grateful for all the work you're doing for understanding surgical ergonomic issues and bringing it to light in a formal way that allows people like me to learn much, much more about it instead of just, being tired and sore at the end of the day, to actually think about all the ways that we can improve not only our own surgical positioning, but also our trainees, because that's why we are in academic places, right? So we get to teach and we get to hopefully make the next generation of surgeons better than we were.
I think what you mentioned about funding is crucial. There's a branch of the NIH. It's called NIOSH. It's the National Institute of Occupational Safety and Health. And, essentially there's been more funding for firefighters and, policemen and, other fields, as opposed to the impact of poor ergonomics on surgeons. And I would love to see more funding mechanisms to further our understanding of work-related musculoskeletal disorders as well as interventions.
It's exciting. It's a great resource for funding for those out there who are interested in doing this type of work. And it's not obviously just gynecology. Back in January of this year, BackTable VI podcast tweeted that they're interested in doing a podcast on neck health and ergonomics in the lab and the OR. So this is something we're all talking about, right? And this is something that needs to be addressed. And so Dr. Amy Park, thank you so much for being a guest here today on BackTable OBGYN. It's an absolute pleasure for me to get to chat with you at any time. And I know you're busy, but thanks so much for making time for us today.
Thank you so much, Mark, for having me. And it's my pleasure and honor to be here.